Welcome everyone, and thank you very much for joining this Circle seminar. It's a great pleasure to introduce you to some very good friends and collaborators of the Circle team. Jon Glasby and Matt Bennett are both really key members of the Sustainable Care programme that we currently run, which many of you who are joining the call will know about. And so it's really a pleasure for me to introduce them, to give them the opportunity to talk about what I think has been a very important paper that they've recently published in the Journal of Social Policy, based on a piece of work that has really sets out some of the important challenges that we need to understand as we think about the future of care in this country. So with lots of relevance, and both technical and in terms of the future of arrangements around care for other countries too. So I'm not going to say much more about them, but except to say that Jon is Professor of Health and Social Care at the University of Birmingham. He has a number of significant external roles, including as a non-executive director of an NHS trust in the Midlands here in England. And Jon also is well known for his extensive range of publications, which include important work that he's done in the past on direct payments and on helping many generations of students to understand what social care is in the UK through a number of his books, which have been widely read. Matt is a talented statistician who has made a really important contribution to the Sustainable Care programme, particularly through the work he's been doing on the costs and contributions of care. And this has been an opportunity for them to bring together a piece of work which I think we can be very proud of, and I'm very delighted to give them the opportunity now to introduce you. Without more ado, I'll pass you over to Jon and Matt to make their presentation. So thank you very much indeed.
Thank you, Sue. Thanks for that really kind introduction, and thank you for inviting us to present today. I'm going to start and end the presentation with Matt doing some of the detailed analysis in the middle, and we'll use that as a basis for the subsequent questions and discussion. We're recording the presentation and the input, and then I think we're pausing the recording at the end of the input so that the discussion isn't recorded, is my understanding. What we're hoping to do today, as Sue said, is to present a slightly unusual project which builds primarily on a work package within our ESRC Sustainable Care project, now published in the Journal of Social Policy. And that journal article is free to access, so people can follow up the detail if they would like. It's an analysis of current and future adult social care spending, but unusually it builds on some initial analysis and some policy advice that we provided for the Department of Health and for Downing Street back in 2010. So relatively unusually, in my experience, we've had the opportunity of working on this with policymakers 10 years ago, then of coming back to it 10 years later. And we've had the opportunity to see what actually happened in practice in between, and what the decade that we've just been through means for our projections and our analysis going forwards. And we'd argue that this work, that the article and the analysis raises really crucial policy issues, but issues that have often been neglected by successive governments. And a number of people quite sceptical, I think, that this time round might be any different. I think one commentator suggested that since the late 1990s, we've had 12 white papers, green papers, official consultations and reviews, and vision documents on these kind of issues. And in my reckoning, we've implemented the funding elements of none of those 12. So it's possible that it may be 13th time lucky this time round, but equally it may not be. Just as some background, there have been some long-standing debates about how best to organise and fund long-term care for older people in particular, and also people of working age, and indeed how to fund the adult social care system more generally. Many governments have started on this route, often found that it's too hard, and then kicked it into the long grass on multiple occasions in the past. The sector, though, has been really struggling financially for many years, and I think the neglect and the fragility of the sector has been even more tragically exposed during the pandemic than was the case before. Now, at the University of Birmingham, we were invited to carry out both the reform and the future funding of adult social care in the run-up to the 2010 general election and the white paper that the then new Labour government produced. Interestingly, the work initially was jointly commissioned by the then Department of Health and by Downing Street. And working with those two different commissioners at the same time gave us some very interesting insights into the policy process, which I won't cover in the formal presentation, but I'm happy to pick up in questions and discussions afterwards, not least when we've stopped recording. That background analysis, which is still available online if people are interested in the original report, set out a series of different rationales or reasons why we might want to reform adult social care. It looked at 5 particular reform agendas that seem to have been very significant under different governments and likely to be significant going forward. And then in particular, it set out 3 different scenarios for future reform and funding, drawing on the so-called one-less scenarios that had been developed when we were looking at the review of NHS funding. And that work by Derek Wanless had been so significant in terms of NHS reform and NHS budgets, as New Labour effectively tripled the NHS budget in response. And we drew on a very similar methodology and approach, applying those concepts to adult social care. In that 2010 work, we concluded that doing nothing is not an option. We felt these were really urgent issues and likely to get even more urgent. In terms of the underlying rationales for social care reform, we argued that part of the reason why different governments seem to have struggled with social care reform over the years is because we were seldom clear about the underlying rationale, what we were trying to achieve. And we identified these 5, there may be others as well. Some of the debates that there have been seem to be about trying to maintain social expectations that the state will provide a degree of support for its most vulnerable citizens. It was a kind of basic safety net type approach, and that may be one reason why we invest in social care. A second reason, though, may be about supporting people to have greater choice and control over their own lives and hence over their services, and hence over their lives, an investment in citizenship, if you like. A third reason might be enabling people to remain independent and healthy and well for as long as possible, so that their needs don't deteriorate, and so that we work preventatively to avoid a future and indeed a more costly crisis, costly both in public spending terms and in terms of the human impact. Fourth, we might invest in social care as a way of providing support to those in need so that they can carry on contributing as active citizens, as people who work and pay taxes, as people who volunteer and play a role in their communities. So an investment in social care could be about a broader investment in active citizenship. And then finally, we suggested a number of social care reforms seem to have been based on the desire to reduce some of the negative impacts that there can be for families and individuals if services are poor or if support is limited. So this could be about supporting carers, either so that carers can carry on to be active citizens in their own right, or because carers have the same human right to a good quality life as anybody else. So part of what was needed, we argued, was to be clear about the reasons in which we were investing in social care. And we argued in particular that we needed to move from a situation that saw social care as something that was subject to the bare minimum, a basic safety net, where governments would invest as little as one could get away with, if you like, to a situation in which adult social care was seen as a form of social and economic investment that benefited all of us, actually, from that investment. When it came to some of the reform mechanisms that different governments had often looked to, we identified these 5. The first was around strategic commissioning, with a purchaser-provider split, and where governments were seeking best value for the money that they were spending by commissioning services from a mixed economy of care. There have been a series of reforms over time that were about greater collaboration between health and social care, on the assumption that agencies working together might meet needs more fully or more effectively. They might reduce the costs of operating independently of each other in terms of either gaps or duplication. A third agenda was around personalisation, using direct payments and personal budgets in particular to try and achieve better outcomes for either the same, or at the time it was suggested, possibly even slightly less money for some user groups. A fourth reform mechanism that governments had often focused on was around the use of technology, particularly focusing on telecare, but I guess more recently focusing on other forms of technology to improve the efficiency and the effectiveness of current working practices. And then finally, governments had often talked about and looked to workforce reform to try and reduce the costs that are associated with unfilled vacancies, the use of agency staff and absenteeism. And for each of those agendas, we looked at the evidence base as to what had been achieved in the past and what the evidence suggests was possible to achieve. And we set out some scenarios that governments may want to aim for or think about when they were planning subsequent reform and subsequent spending. And in our 2020 work, we revisited some of those evidence bases to update in light of more recent knowledge. And then all that analysis went into three possible scenarios for adult social care reform and spending, using the terminology and the concepts that have been developed by Sir Derek Wanless in his review of NHS funding. One of the scenarios was a slow uptake scenario where things carry on largely as they are. There's some reform, but it's not very meaningful. Things come and go. There isn't really a concerted attempt at very radical reform. And under that slow uptake scenario, we projected that adult social care costs would double within 2 decades. And those costs that would double were for existing services as they were in 2010, which many people argued weren't sufficient to meet need and weren't of sufficient quality in some respects. So we would see even the cost of those services doubling. Not a doubled budget for improved outcomes or improved services, a doubling of the budget just for existing services as we responded to rising need and changing demographics. There was then a solid progress scenarios where some reforms are attempted and some of them work to a degree, and there's a degree of continuity and commitment to reform over time. And under a solid progress scenario, costs were broadly contained at 2010 levels. There was then what Sir Derek Wanless describes as a fully engaged scenario, where there was the scope for a 2% reduction in costs, although I should stress that the assumptions within the evidence base there were almost heroic. Any possible benefit that it was possible to anticipate from the research evidence, all of those would have to be achieved consistently and across the board to achieve that fully engaged scenario. But effectively 3 different scenarios for adult social care reform and spending, where if we carried on as we were, costs would go up like that. A solid progress scenario where we could constrain costs much more effectively, and a fully engaged scenario where it may be possible to achieve broader outcomes and possibly even reduce costs to a certain extent. And then just in terms of what happened next, well, although we concluded that doing nothing's not an option, that turned out to be overly optimistic. What followed, we argue in the article, has been characterised as a lost decade for social care reform, where a number of reforms stalled and where a number of things, we would argue, went backwards between 2010 and 2020, not least because of the period of austerity that local government more generally experienced during that time. And in the article, we set out some very real impacts in terms of both unmet and undermet need, in terms of the quality of care, in terms of the pressures that have been experienced over that decade by carers, by frontline social care staff, by organisations trying to provide adult social care services, and in terms of the knock-on effect on partner agencies, particularly the NHS, but possibly other partner agencies as well. And we published that analysis in a broader social policy journal. And my personal view is that some of the social policy journals haven't always been as focused on adult social care as they might be. I suspect the number of social care articles compared to other areas of the welfare state, maybe smaller. And so one of the things we were trying to do in that article was to explain why these things really matter. And the following slide is quite a lengthy quote, but it was an attempt to sum up why this is a big deal really for a broader audience that may not be steeped in adult social care. So many of the impacts summarised in the article involve people and their families suffering quietly in their own homes. The sheer human misery caused by our lost decade is simply not as visible as financial pressures on more prominent, popular and better understood services, hospitals or schools, for example. When social care for older people, and as Matt will explain later, one of our focuses was on older people. When social care for older people is cut to the bone, lives are blighted, distress and pressure increases, and the resilience of individuals and their families is ground down. Yet this happens slowly, day by day, week by week and month by month. It's not sudden, dramatic or high-tech in the way a crisis in an A&E department may be, and it tends to attract less media, political and popular attention. Now, the articles had quite a lot of impact. There was a piece in The Guardian that went alongside it. It seems to have been cited quite heavily and picked up by other people. But actually, the bulk of the response has been not to the analysis, but to passages like that try and articulate why these kinds of things matter. And I know that doesn't need explaining to this audience at all, but I've been struck by how often that kind of paragraph has been quoted, for example, by people on social media or elsewhere, trying to talk about why these things really, really matter. At that point, I will hand over to Matt to take us through some of the detail of the analysis.
So just before we go into the sort of quantitative analysis that went into this paper, just to say that these are available in the freely accessible paper as well, if anyone would like to see it in the paper. And just also to say that two of our colleagues, Patrick Hall and Yanan Zhang, also contributed to the paper more generally. But Yanan Zhang, who I know is here today in the seminar, and was really fundamental in the quantitative analysis that we undertook. And I'm sure she might have some points to make at a later point. But just to sort of give you an overview of the gross expenditure on adult social care in the last sort of 20-25 years, and you can see here that how in the graph, based in cash terms and also real terms, how expenditure increased right up until sort of 2010, when we hit that recession, and then significant austerity policies, which we then saw significant decreases or reduction in adult social care spending. We found about 8% reduction in spending in that period. But also just to say as well, I think John has already alluded to the fact that this is quite an interesting paper because John had conducted some of this work just over a decade ago with Downing Street, thinking about these reform scenarios and what that might look like. So here is sort of, I guess, empirically looking at that lost decade. Here we have these funding scenarios or reform scenarios in these three separate graphs. We have a graph here, graph A, which is the gross spending on working age adults with physical impairments, learning disabilities or mental health problems. We have the different reform scenarios where fully engaged, where we see a 2% decrease in costs. We have solid progress, and then we have slow uptake as a 2% cost growth. And what we also have is what actually happened in practice, so the actual spending that occurred over that time period, which we didn't have at the time, obviously, when John conducted these analysis and applied these reform scenarios. So we have the sort of working age population here, and then there were sort of issues with data discrepancies and changes in the ways that costs were reported over that time. So we have two separate graphs for people aged 65 and older, so spending on residential and nursing care, and then also spending on community services. And I think what the real striking thing is here is that if we take the slow uptake scenarios, blue as being the actual costs of care, we can see how sort of spending really matched those costs. And so here you can see that for the working age population, we see that expenditure or spending broadly matched the costs. But what we see is when we look at break that down by the over 65s is that we really see a massive reduction in spending based on the cost. So you can see here the yellow lines. The yellow line is really quite dramatically and massively different from what we would expect the true cost to be. So that's something that I think is sort of really interesting and really sort of highlight the importance of Jon's point about ageism and an aging population and the elderly being or older people being significantly affected by this lost decade. So what we also did, we didn't just look at this for that lost decade time point. We also made long-term cost projections under the 3 reform scenarios that Jon has already outlined. I just wanted to sort of look through these different projections, bearing in mind the different assumptions that we built into these models. So we're really interested in the population change and numbers of people across different age groups, the number of people receiving support by the type of care and again by age group, and for spending on adult social care for long-term and short-term support across those different age groups too. And what we did is we used a proxy for government financial capacity. So we used something called gross value added, which is an indicator of tax revenue related to local economies, to help us project the ratio of gross spending on adult social care to gross value added, and you know, the government budget and the government funds available for spending are sort of crucial when we're sort of thinking about this these kinds of projections. So again, we assume that the proportion of people in different age groups receiving long-term and short-term care is constant, so that doesn't change over time, although the real, the absolute numbers obviously will, because more people will, with the aging population, more people will age, so a higher number of people in absolute terms will require services. I think the last point that we wanted to really think about was in some of those earlier the lost decade projections, we were really thinking about how GVA, gross value added, changes over time. And so we're assuming that gross value added changes or increases by 2% annually. And this is going to be, I think, hugely important for something we're going to show at the end of this analysis. And actually, it was just a sort of an intellectual exercise at the time to demonstrate the importance of local economies and resources to spend or expenditure on adult social care. We didn't know that we were going to go into a pandemic. We didn't know that there would be, you know, probably a major recession. So I think that actually those findings that we had, that we published, you know, a year ahead of time, are you know, will have huge implications for what we're going to see moving forward. So here we have our projected gross spending on long-term care for older people 65 and above. And so all of the graphs that I'm about to show you follow this general pattern. And the information in this table really is also displayed in this graph as well. So we used lots of information from various data sources to capture the number of people receiving care in 2018. So in terms of long-term care for people aged 65 and older, this was 565, just over 565,000 people, and you can see what this looks like over time in terms of absolute numbers who will require this type of care all the way up to 2060. And then here we have our reform scenario, so our fully engaged scenario, our solid progress scenario, and our slow uptake scenario. And what we see is actually it's only the fully engaged scenario where we see costs reduce or spend reduce, cost reduce, the spending reduce over time, and you can see this in our graph here. So the red fully engaged scenario, we can see that those spending really does reduce. Whereas with the other scenarios, particularly the slow uptake scenario, we see that they increase. We see a similar pattern here again in terms of projected growth spending on long-term support for working age people. Again, we have our population projections here from all the way up to 2060, and we see that the fully engaged scenario really is the best scenario for making those savings. Similar pattern here with projected growth spending on short-term care for older people. Again, the graph represents what we see in these data tables. We see that the number of people receiving support in 2018 was about 183,000 people, and that increases to 307,000 people in 2060, and then the associated spend in millions here in the table. So I'm just going to skip through these next two slides just so I can get to the importance of gross value added and the 2% increase that we built into our models based on past historical data. I think this is quite important, because here what we have in these two slides is what this looks like over time historically. These dotted lines here on the graph indicate the lower bounds and the upper bounds for government spend. And what we see here is that even in the slow uptake scenario with 2% growth, we see that we will broadly fit between these historical trend lines, the lower and the upper bound. It's more to the upper bound, but it does broadly fit within that and within those historical time trends. However, when we start to think about GVA as a no percentage increase, we can see really quite dramatically, quite quickly, that our costs really do extend, or that the spending really will exceed those high historical values as early as, I don't know, it looks like about 2027, 2028. So the importance of the local economy, I think, is really fundamental when we're thinking about adult social care spending in the future. John, do you want to continue?
Yeah, thanks, Matt. So to cut a long story short, we've tried to highlight the very real impact of that lost decade between 2010 and 2020. And as Matt said, the impact has been particularly acute in terms of spending on services for older people. That might be for various reasons. We've got a cohort of young people probably with very complex and expensive needs who've been turning 18. They've survived into adulthood in a way that they may not have done previously due to advances in medical technology. And that's a major achievement of our welfare services and our welfare state. But it probably means that there's a number of younger disabled people who have very expensive care needs that will be receiving services that may not have been the case in a previous generation, for example. And there's limited scope for rehabilitation or prevention. Those people, once they've reached 18, are likely to carry on needing that level of support. So there's various reasons why that might be the case, but it's also quite hard to believe that it isn't due, at least in part, to ageism. That when we have to make very difficult decisions about funding cuts, that as a society we find it easier to make those cuts in some services for older people, particularly services that tend to be out of sight and out of mind, rather than in services for people of working age. As Matt said, what's available to spend depends on the economy, but also on the choices that we make as a society. So in many of the debates that I have around the reform of adult social care services, someone will tell me that they can't do something that seems sensible because we can't afford it. And that sounds like it's an economic argument, when actually for me it's a statement of priorities. We could afford it tomorrow if we decided collectively that it was sufficiently important. We just have to make some really difficult choices about what other things we didn't do as a result of the choices we make. So claiming that something's unaffordable sounds like an economic argument, when to me it's a political argument and a statement of priorities. But what the government has available to spend on these issues depends very significantly on the economy, and the two previous graphs that Matt showed illustrate that really well. What's really clear is that reforms needed now. Governments will face greater financial stress the longer they wait to intervene in a system that is already at breaking point, if not already having passed that point, and that's in desperate need of reform. So actually, with even more urgency than in 2010, we conclude that doing nothing is not an option, with the not underlined and in bold and shouted out loud.